Good afternoon. My name is Brian O'Mahony, and my topic this afternoon is new therapeutics in hemophilia. Now, my viewpoint is that of a patient expert. I am not a clinician or a hemophilia treater. So the therapeutic landscape in hemophilia has changed dramatically in the last 5 to 7 years. Up until 5 or 7 years ago, the mainstay of treatment was coagulation factor concentrates, either factor 8 or factor 9. We've now been joined by other novel therapeutics and with many others coming down the tracks in terms of clinical trials. So currently for factor 8 deficiency, we have 35 licensed plasma-derived factor concentrates, 7 recombinant, 5 extended half-life. We have a bispecific antibody, emicizumab or Hemlibra, and in the past 10 days, we've had the first licensed factor 8 gene therapy licensed by the EMA. In clinical trials, we have fitusiran, we have 2 anti-TFPIs, not 3. We have Serpin-PC. We have a new extended half-life factor 8 called BIV001, other bispecific antibodies, which will be competitors to emicizumab, implantable spheres, and 2 phase 3 gene therapies with many others in earlier phases of development. For factor 9 deficiency, similar picture, we have 18 plasma-derived factor concentrates, 3 recombinant and 3 extended half-life. And in clinical trials, we have fitusiran, 2 anti-TFPIs, Serpin-PC, implantable spheres, and 2 phase 3 gene therapies, with many others also in earlier stages of development. For inhibitors, for many years we were reliant on FIBA or recombinant factor 7A. There is now a new licensed bypassing agent, Serpin-7fact, which is based on transgenic rabbits. We have emicizumab or Hemlibra for factor 8 deficiency with inhibitors. And in clinical trials, we have improved bypassing agents, fitusiran, 2 anti-TFPIs, Serpin-PC, and a gene therapy under development for factor 8 with inhibitors. And the development pipeline in hemophilia is amazing. On the left, you will see the Irish Hemophilia Society's publication based on the EU Novel Treatments in Hemophilia and Other Bleeding Disorders regular review. And there are so many clinical trials and so much new data emerging that this review is published twice a year, and it typically runs to about 40 pages. So this is just giving you an idea of these are the summary tables from one of the last issues. These are replacement therapies in development and bypassing agents in development. These are non-replacement therapies in development. These are gene therapies in development for hemophilia A, more for hemophilia A, gene therapies for hemophilia B, and cell-based therapies in development. If any of you are interested in looking at these publications, you will find all the issues on the Irish Hemophilia Society website at hemophilia.ie. Not all the products will make it to the market, but there are so many under development that I'm confident that many will make it to the market. In the last year, we've had a number have stopped development, including Mars-AA, a bypassing agent. The Pfizer factor 8 gene therapy was temporarily placed on clinical hold due to supernormal expression. The implantable spheres for factor 8 development was halted due to inhibitor formation, and a Generation Bio company lipid nanoparticle delivery system was halted due to significant variability. So some of the clinical trials will fall by the wayside. Now, in terms of extended half-life factor concentrates, these have now been on the market for 6 to 7 years. There are 5 licensed extended half-life factor 8 concentrates. 3 of these, the half-life is extended using pegylation. 1 is a single-chain polypeptide, and 1 is FC fusion, using the FC portion of a human immunoglobulin. And for factor 9, there are 3 licensed extended half-life factor 9 concentrates. 1 is FC fusion, 1 is albumin fusion, and 1 is pegylated. Now, the half-life extension of the factor 8 is limited by the length of von Willebrand's. So typically, all of the extended half-life factor 8s have a half-life extension of about 1.5-fold compared to normal factor 8. For the factor 9s, they don't have the same limitations, so the half-life extension is significantly higher at 2 to 5 times the half-life of the existing recombinant factor 9. Having said that, you also have to be aware when using the extended half-life factor 9s of the differences in extravascular distribution. Not all of these EHL factor 9s have the same extravascular distribution, and that's a factor to take into account when looking at efficacy. And certainly the much higher half-life extension with the factor IXs means that the APR reduction is more pronounced using those products than in patients treated with extended half-life factor VIII products. Now, typically at the moment with the extended half-life factor IX products, they can be infused prophylactically once a week, once every 10 days, and once every 2 weeks, giving a significantly high trough. So the half-life extension of the 9 is high enough to permit less frequent infusion and a higher trough to give more protection. Whereas with the currently licensed extended half-life factor VIIIs, they typically have to be infused twice a week for prophylaxis, and they will either give you a higher trough if you treat 3 times a week, or a lower frequency of infusion, but typically not both benefits. The next extended half-life factor VIII, which is currently in clinical trials, BIV001, is a novel fusion protein which uses the Fc fusion extended half-life factor VIII and also links that to the DD3 domain of von Willebrand factor and an X10 polypeptide. And the early results from this have shown a half-life extension that's 3 to 4 times as long as that of standard recombinant factor VIII, thereby allowing prophylaxis once a week with a trough level in excess of 10%. Emicizumab is a licensed bispecific antibody which is directed against activated factor IX and factor X, and it functions as a bridge between factor IXA and factor X in the tenase complex and mimics the function of activated factor VIII. And this can be used for patients with factor VIII deficiency without inhibitors or with inhibitors. And it basically, there's a loading dose given over a 4-week period, and then a dose of 1.5 milligrams per kilogram, either weekly, every second week, or every 4 weeks. And it gives you a steady state level of protection. So the exact way in which you compare this to factor VIII trough levels is not clear, but most people would think that and most studies have shown that it's typically equivalent to a 10 to 15% trough level with factor VIII. And it's used for prophylaxis in adult and pediatric patients, and indeed it's been used now in newborn at every age from newborn and older with hemophilia A with or without inhibitors. It's subcutaneous administration once a week, once every 2 weeks, once every 4 weeks, and it gives you a steady state. And we've seen high efficacy in clinical trials with a low overall bleed rate and a significant proportion of people with zero bleeds. And indeed, it is now used in many countries around the world and has particularly been a game changer for people with factor VIII with inhibitors, massively decreasing our annual bleed rate and giving them more protection. And is also gaining a significant market share for factor VIII deficiency in many countries. And in a study that was looked at 21 countries, and this study is almost 2 years old at this point, but it was available for 100% of inhibitor patients and about 88% of non-inhibitor patients. And certainly in my own country, all inhibitor patients with factor VIII inhibitors are now using emicizumab, and it is a therapeutic choice for every patient with severe factor VIII deficiency. The safety profile, there have been thrombotic events reported with the concomitant use of fiber-activated prothrombin complex concentrates. And so there are new treatment guidelines for the treatment of breakthrough bleeds, where they recommend that in inhibitor patients use factor VIIa, or if you have to use APCC, use very low doses. Now, in addition to emicizumab as a bispecific antibody, several companies are working on coagulation agents or rebalancing agents, which basically decrease the impact of the naturally occurring anticoagulants. And they include fitusiran for hemophilia A and B with or without inhibitors, anti-TFPIs, and Serpin-PC. And all of these therapies are administered subcutaneously, ranging from daily subcutaneous injection to once a month. They can only be used for prophylaxis. So if the individual is on these products for prophylaxis and they get a breakthrough bleed, they still have to use factor concentrate for that breakthrough bleed. They provide stable protection without peaks and troughs, but they can be used for hemophilia A or B with and without inhibitors, and they all have different mechanisms of action. The first of the anti-TFPI is concizumab. If we look at the phase 2 data, you can see the outcomes there in terms of bleeds. Still a significant number of bleeds in hemophilia with or without inhibitors, and in hemophilia B with inhibitors. And the second anti-TFPI, marstacimab, in 20 patients with hemophilia A with or without inhibitors, the ABR decreased by 85% and 93% in the different dose cohorts. And there have been some thrombotic events with concizumab. There were non-fatal thrombotic events in 3 patients. And in marstacimab, there were no thrombotic events. The most common adverse events were injection site reaction. 3 patients did develop anti-drug antibodies without neutralizing activity. Fitusiran is an siRNA-based drug which can also be used to treat people with hemophilia A or B with or without inhibitors. It's an RNA interference therapeutic, which would require a monthly subcutaneous injection prophylactically. And we've seen a reduction in annual bleeding rate in the clinical trials with this product in phase 1 and phase 2, and 48% of the patients were bleed free. And again, in the phase 3 data, we saw a significant reduction in the annual bleed rate for all treated bleeds and for joint bleeds, with just over 50% of patients being bleed free. SERPIN-PC is a serine protease inhibitor which naturally inactivates activated protein C by promoting thrombin generation. And the data from the phase 2 studies, there's limited data on this at the moment, but again, in 23 patients, monthly subcutaneous injection, a median 88% reduction in annual bleed rates, or 94% reduction in annual bleed rate for spontaneous joint bleeds. So again, very promising. And indeed, as you can see, a lot of these rebalancing agents, which work on the other side of the coagulation cascade, are under development. They're in late-stage clinical trials, and I think they have the advantage that they can potentially be used for hemophilia A or B, or A with inhibitors, or B with inhibitors. Gene therapy has been under development for more than 25 years in hemophilia, and various efforts have been undertaken over the years, and they always run into 2 basic problems. One, they could not get a significant factor expression, and even if they did, they had no durability of expression. And I think that the first factor 9 gene therapy trial undertaken successfully by Natwani and Tottenham in UCL in London 10 years ago now showed a sustained factor expression of about 5%, which has been up to 5% in number of patients, and they've now been treated for almost 10 years, and that has shown durability. So in terms of hemophilia gene therapy, there are currently 16 gene therapy trials in phase 1 and 6 in phase 3. People are looking at different types of viral vectors, including AAV and lentivirus, but currently the AAV vectors are the only ones in clinical trials. They use different vector types and dosages. In the hemophilia B trials, most of the trials have now switched to using a super factor 9 gene called the Padua variant, which gives you a higher level of factor 9 activity. And in all the hemophilia A trials, a codon-optimized beta-domain deleted factor VIII is used so that the factor VIII gene will fit into the viral vector. And in the last 10 days, the first factor VIII gene therapy, Velactocogene roxavar-parvovec from BioMarin, brand name is Roctavian, has now been licensed by the EMA. So finally, we have the first licensed hemophilia gene therapy. And when we look at the hemophilia A BioMarin 2-year results in the phase 3 trial, you're seeing a significant increase in factor expression and then a slow and steady drop off. And the lighter blue line here is a small number of patients in a subset of 17 patients for whom they had 3 years data at that point. And you can see a clear progression here where the factor VIII goes up, and then you're seeing quite a variation, of course, in factor VIII expression, but then there is a significant decrease in expression over time, up to 3 years in this particular study. And the phase 3 BioMarin data, when we look at the small number for whom they had 2 years of data, 15% of those after 2 years had a factor level in the normal range, greater than 40 IU per deciliter. 26% were between 15 and 40 IU per deciliter, 35% between 5 and 15, 10% between 3 and 5, and 14% less than 3. And using the chromogenic assay, 3 IU per deciliter is the limit of detection. So you're seeing significant factor expression, but also a significant change even between year 1 and year 2. And in the full cohort of 132 people with hemophilia in the phase 3 trial, the mean factor VIII expression was 43 IU per deciliter, and the median was 24. But in a smaller cohort where the year 2 data, the mean was 24 and the median was 15. So you are seeing a significant change from year 1 to year 2. But the factor IX gene therapy, the most advanced clinical trial is the CSL Unicure trial, AMT-061. And again, here you're seeing significant factor expression, but looks quite steady. And the mean factor IX expression at 1 year was 39 IU per deciliter. Sorry, at 6 months, 39 IU per deciliter, and at 18 months, that was more or less unchanged at 36.9 IU per deciliter. There are a number of unknowns with gene therapy. So we are in a very exciting phase where we have the first licensed factor VIII gene therapy. We anticipate the first licensed factor IX gene therapy from CSL Unicure will almost certainly be licensed in the next year and perhaps in the next 6 months. But there are unknowns with gene therapy. So the factor expression, there's a wide variability from no increase in expression to supernormal. As you saw earlier, a significant number of people with hemophilia in the trials achieved very good factor expression, but there is a wide variability. In terms of predictability, you can't predict which people with hemophilia will not get a good response. And with the factor VIII phase 3 data, 9% were under the limit of detection at 3 IU per deciliter. So about 1/10 of people may not get a good response with factor VIII gene therapy. The concern is you can't tell beforehand. You can't predict who will not get a response. In terms of durability, we don't know how long expression will last. There are certainly differences between factor VIII and factor IX. In terms of safety, there are short-term safety requirements. There's a requirement for steroids in the BioMarin phase 3 data. Steroids were used by approximately 80% of people, whereas with the phase 3 factor IX data, steroids were required for about 17% of people with hemophilia. So there is a requirement for steroids to deal with the transaminitis, which occurs due to vector infusion, and also a long-term risk of insertion mutagenesis. Now, the AAV vector is effectively non-integrating, but it's now agreed that there is some small degree of integration, and there is a theoretical risk of insertion mutagenesis. There have been 3 cancers in various hemophilia gene therapy clinical trials, but the detailed investigations have concluded that none of those was linked to the vector which was infused. In terms of eligibility, that is fairly clear, and probably 40 to 50% of those with severe hemophilia will be eligible for gene therapy. You exclude those, you exclude children, because this is only going to be licensed for people over the age of 18. You exclude those with pre-existing inhibitors. You exclude those with antibodies to the AAV vector, which is being infused, with the exception of the CSL Unicure factor IX gene therapy, where they can actually treat people with pre-existing antibodies to the vector. You exclude those with active liver disease, and some trials will exclude those with HIV. So when you take all those exclusions into consideration, only 40 to 50% of adults with severe hemophilia would theoretically be eligible for gene therapy. And of course, affordability is going to be an entirely different discussion, and certainly for many countries we require new payment models, because a one-off payment model would have a massive budget impact in many countries. In terms of durability, how long it will last, we don't know, we're not sure. But clearly with the hemophilia A, when you're looking at a drop-off, it all depends on where that curve ends up. and you can extrapolate current data. But it's certain, I think a lot of people's current estimates are that you may well get significant expression for somewhere between 5 and 8 years. For hemophilia B, it looks very much like the durability is better, and that you may get expression for 10 to 20 plus years with hemophilia B. In terms of safety, obviously with the need for steroids, with the impact on the liver, there's a need for ongoing monitoring of liver health on an ongoing basis. Certainly in the first year post gene therapy, transaminase levels have to be tested very frequently, because if you miss even a small degree of transaminitis and don't start steroid therapy if it's required, then you can actually lose the factor expression. So you need ongoing monitoring of liver health, and in the longer term, ongoing monitoring to make sure that there's no increased incidence of cancer due to insertion mutagenesis. And of course, these are rare therapies in a rare disease. So if you want to spot these rare adverse events, you really do need a global registry, and the World Federation have initiated a global gene therapy registry, and we will be encouraging every country and every patient who is treated with gene therapy to enter this registry. I think the core outcomes of gene therapy have been agreed, and were agreed by a group of experts who met some years ago while the clinical trials were really in phase 1, phase 2. And rather than just for many hemophilia products, the regulators will look at annual bleed rate. And yes, that is an important outcome, but we also believe that factor expression, duration of expression, impact on chronic pain, mental health, annual bleed rate, and resource use are outcomes that should be looked at. And in fact, several expert patients with hemophilia published an editorial in Hemophilia where we felt that factor expression was the main outcome that should be looked at. And indeed, if you get a good factor expression which is sustained, that really will have an impact on your chronic pain, and perhaps certainly on your resource use and on your annual bleed rate. So I think this whole complexity of therapies has put us in an entirely new paradigm in terms of decision making for hemophilia, and the change from standard to extended half-life, then the first licensed bispecific antibody, now with the rebalancing agents coming down the line, and with the first licensed gene therapy, there is definitely a requirement for shared decision making between the doctors and the people with hemophilia, and also collaboration between the patient organizations and the doctors in terms of education and information to people with hemophilia. And I think we have to examine the treatment alternatives for individuals with their treatment goals in mind. It needs a discussion, needs to explore the goals and compare treatment options, look at values and preferences, and then make it a joint decision, and then review the decision and see how it has worked out. Thank you very much.